Good afternoon, everyone. Welcome to the Population Health Collaborative 2021 conference. I am Suzanne Lawson with Constellation Consulting, and we are the convener for the collaborative. The Population Health Collaborative is funded by the New Mexico Department of Health, Heart Disease, and Stroke Prevention Program. You can learn more about the Population Health Collaborative, as well as join the PHC discussion forum at www.nmhealthequity.org/PHC. Please note that this meeting is being recorded. Attendees' cameras and microphones are activated today. However, we do ask that you keep your microphones muted. Following each of today's presentations, we will have time for Q&A. You may ask your questions live or post your questions in the chat window. As we begin our first Population Health Collaborative conference, we are pleased to welcome Dr. Tracie Collins, Secretary of Health for the state of New Mexico. Prior to her role as Secretary of Health, Dr. Collins was Dean of the University of New Mexico College of Population Health. Dr. Collins has served in a variety of academic leadership roles, in addition to providing clinical care and conducting and overseeing clinical research. She has also produced nearly 80 scholarly publications over the course of her career, and she maintains a clinical practice as a vascular specialist. Dr. Collins earned a Bachelor of Science degree in chemistry from the University of Central Oklahoma, a Doctor of Medicine from the University of Oklahoma College of Medicine, a Master of Public Health from Harvard University, and a Master of Healthcare Delivery Science from Dartmouth College. Please welcome Dr. Tracie Collins.
Good afternoon. It's my pleasure to be here, and thank you for that wonderful introduction. Let me go ahead and get started with my presentation. I'm just going to try and get my slides up here. 1 second. Okay. There we go. All right. Can everyone see my slides okay? Okay. All right. Let me enlarge this. All right. So wanted to spend some time today visiting with you a bit about myself and to talk about what we can do in population health to address some of the key issues that are affecting New Mexicans. And so before I delve into the cardiovascular disease issue, a bit about me as far as my background in internal medicine and vascular medicine. I've spent a lot of time with looking at peripheral artery disease or poor leg circulation and its impact on minority communities and its association and risk for amputations or limb loss. So a lot of my work in the past and moving forward has been on interventions that really help to reduce morbidity and mortality from peripheral artery disease. Now, me being at the state as secretary, obviously we've been in a pandemic and it continues, but the attention is really focused on how do we keep New Mexicans safe during this pandemic. And so early on, you saw the governor moving people to quarantining, staying at home, isolating, distancing, mask wearing. And then we were fortunate to have the vaccine. But one of the issues with the vaccine is that not everyone agrees that it's something that they need. So right now, the supply of vaccine is outstripping the demand. And what we're doing currently is addressing the issue of vaccine confidence, helping to remind people about the value of the vaccine, that you're more likely to suffer a complication from COVID or even suffer long COVID than you are to have a complication from one of the 3 vaccines that we're currently using, Moderna, Pfizer, or J&J. But what this pandemic has shown us is that we have systemic issues that put certain groups at risk for poor outcomes. And those groups are largely communities of color. They're also rural populations. And so when we think about population health in the time of a pandemic, we're really working closely, seeing the close working relationship between public health and healthcare delivery as a way to contain and control this pandemic. And so when you think about population health, it is clearly a partnership between public health and healthcare delivery. Think of Dr. Fauci and his messaging and trying to keep hospitals from being overwhelmed, which has been our original goal. And now it's to keep people alive and continue to keep them out of the hospital but it's also to open things up because economically we've been challenged with how we've had to handle the pandemic with reducing limits in businesses, cutting back on activities. And so here's our chance as we look at public health and healthcare delivery to really move this country forward and get through this pandemic, but also to address this issue that COVID uncovered, which is structural or systemic racism, where we have certain populations that are more likely to suffer from the pandemic, from the virus, and we've got to do better about those upstream factors, the poverty, housing, transportation, access to healthy foods, those determinants of health that really drive health outcomes. And that's what we do when we target population health. Now, one of the things I was asked to speak about was looking at strategies for reducing the burden of cardiovascular disease in New Mexico. And as an internal medicine doctor and vascular specialist who focuses on PAD or poor leg circulation, I highly value the importance of reducing the burden of cardiovascular disease in this state. And the things that we can look to really address that, we can make use of our electronic health records, gathering data on which patients are most at risk, understanding their upstream factors, and targeting those issues as we try to reduce the burden of cardiovascular disease in the state. We can use a team-based approach. We have community health workers or promotoras who can help really help patients navigate the system and understand what their social needs are. We have opportunities to use self-measured blood pressure approaches, people measuring their blood pressure at home. We have community resources. We want to make sure that patients understand the value of medication and hear their voices about what risk factor or what sort of side effects they're experiencing with these meds, and being open to making modifications so that they adhere to the medications and have better control of their blood pressure. So when we think about equity, we have different communities need different kinds of support. So one-stop shopping is not what's going to work. You have to tailor an intervention to the given needs of an individual patient and to a given community. We must also acknowledge distrust among certain racial and ethnic communities. And so that requires listening to questions and concerns with respect, being open to dialoguing with your patient, and not being the only one talking. Allow your patient to express their concerns and listen. And really acknowledge that it's not just about Tuskegee. There has been issues within our healthcare system that continue since that experiment. And so there's a lot of distrust among communities of color, and we've got to work to help overcome that distrust. We have to acknowledge it and then find ways to improve the trust between patients and providers and the healthcare system. And we also, we have an opportunity to work together. So the silver lining for me for COVID, it's uncovered what we knew has been a problem for a long time, but it also provides us an opportunity to begin thinking about interventions to really help improve the trust that patients have in the healthcare system and to improve health outcomes. And so I'm going to stop there. I thank everyone for their attention, and I'm going to stop sharing so that I can see what questions there might be. So thank you.
Thanks so much, Secretary Collins. So if you have a question for Dr. Collins, please feel free. I see Wayne giving you applause as well. Yeah, so if you have a question for Dr. Collins, please feel free to put it in the chat window or go ahead and unmute yourself. And we do have a few minutes for Q&A.
If I don't have a question, I will ask the audience a question.
Sure.
Yeah, I'm curious as to what some thoughts are on how we build trust between certain communities of color and the healthcare system. If people have thoughts about that, I'd love to hear what your thoughts are.
So I'm actually going to highlight a couple of people. Wayne, I'm going to start with you. So if you can go ahead and give your name and your title and then your response to the question.
Good morning, Dr. Collins, or good afternoon, Dr. Collins. I appreciate your presentation. It's a pleasure to finally virtually meet you. We haven't met in person yet. I'm epidemiologist with the Heart Disease and Stroke Prevention Program and the Diabetes Prevention and Control Program. I split between the two. Those programs, of course, are very, very closely related in what they're trying to do. Both diabetes is one of the principal drivers of cardiovascular disease. And so we're not only really heavily focused on trying to prevent diabetes, but by doing so, that also will do a great deal to prevent cardiovascular disease and particularly peripheral disease. Uh, so in your, I think it was in your last slide, almost everything that you had listed there as things that we should be doing, they are part of the current 1815 work that we do.
Good.
So yeah, it would be, I would love to be able to tell you that we're having extraordinary success. But we have been, you know, in addition to the year that everybody had, 2020, we've also been struggling with personnel vacancies. We've been about half staff for about a year and a half. We're right at the moment, though, the cusp of filling almost all of those positions. So hopefully the latter part of 2021 and 2022 will be, you know, really successful years with a lot of great work, because we've found some really great people coming in, and they'll be in within the next couple of months. We should be almost fully staffed. So regarding your question, it is, as you said, it is a very challenging question, and there's so much history behind it all. It is, as you said, it's well beyond the Tuskegee study, which of course did tremendous damage to trust and appropriately. I mean, it'd be impossible not to have your trust harmed by something like that.
Right.
The same guy set up a similar study in Honduras, and that didn't come out for a long time either. But there is just the entire history of the United States where there's just been structural systems put in place to lock out whole populations from all of the possibility that this country has. So I honestly have struggled. I'm 33 years into my public health career. And I think that, you know, there's the really obvious things that almost sound too soft because they are so obvious, but the obvious things of, you know, community connections, establishing relationships, identifying people that are known and trusted within those communities and establishing relationships with them, those are all fundamental things. We also really have to make sure, though, that our, you know, it's so much, one of the things that has bothered me in my entire public career, health career, is that we always acknowledge, as you did in your one of your earlier slides, you acknowledge the impact of structural racism and what it has done in terms of economic development, access to education, access to employment, access to healthcare. All of that, so much of that anyway, is related to economic development as well as promotion of health.
Yeah.
And in public health, we always, for 33 years, I've listened to us, myself included, acknowledge the profound connection between socioeconomic status, indicators of health, and poor health outcomes. And yet we in public health, we never talk about economic development. And I used to, just fortuitously, I used to commute with a PhD economist. And so we had almost 2.5 hours every day to talk. And at the time, this was 25 years ago, at the time he worked in this tiny little office of economic development that was part of the state government. And there were 4 people in that office. And I understand now that it's a division, or I don't think it's a department yet, but it's a division or an office. It's a much bigger place. and their role is to foster economic development around the state. And I've been in meetings over the last couple of years, I've been asking the question, should we as public health people be developing a relationship with this office or division, whatever it's called now, so that they think about their work, we help them think about their work in public health terms.
Mhm.
They help us think about the ways that we can integrate or at least foster economic development at the same time that we're working on public health. It often feels to me like we're putting band-aids on things, when we're trying to work on public health outcomes, when we know so much about the real drivers of health status of communities.
Yeah.
And it feels like there must certainly be some kind of opportunity there for some kind of integrated approach between those professional bodies. I'll bet you, I don't know this, but I'll bet you they don't think about public health when they're thinking about economic development.
Yeah, no, that's an excellent point. I completely agree. Absolutely, because when you think about what's largely driving health outcomes, it comes down to your, income, where you live. This is all, and so economically, we have to really, as from public health lens, get to the dollars, not just the programs, but figure out how to get the money into the community that needs it. Yeah.
And another problem that we face is so much of our access to healthcare in this country is tied to employment.
Mhm.
So any population that is struggling with really high unemployment is also very likely, or low unemployment, or low and poor employment, right? So they're employed, but they don't have quality health care, or they have very low income. And the way things are going now, I'm a single father raising two kids with type 1 diabetes. So even though I'm, well employed and have what we think of as very good health care, we still, so much of their future
Mhm.
has been shortchanged because of 15 years of paying extraordinary amounts of money just to keep them alive.
Oh my goodness.
And so that's somebody like myself who's well educated, well employed, really good health insurance. So then you translate that to somebody that is in a different life situation where they're maybe earning 20,000 a year, and they have a health plan, but when they finally have to use it, they discover that there's a $5,000 deductible and huge copay. So that's another problem that we face, is so much of our health care is provided through employment, and so then that adds to that problem of economic development.
Right. And these are excellent points. It makes me think about a conversation I had recently with a classmate from Dartmouth. We're planning a symposium, and we were coming up with a catchy kind of name. And we came up with, the tale of two patients, how two patients with similar diseases or chronic conditions have completely different outcomes, and how it relates to some of these issues you're pointing out. The thing he gave me as an example, which was really concerning, he says, yeah, how about if you have two homeless people, one African American or Black, one non-Hispanic white, and you give them the same sort of support, yet the African American still does worse than the non-Hispanic white. So I'm like, well, okay, there's more to tease out, to address. Yeah.
Yep. That goes back to your trust question, probably, and it is very complex. I remember a study that came out of, I think it was a combined study between Harvard and Johns Hopkins, I think,
Mm-hmm.
where they looked at all of the various factors that, education status, employment status, age, race, ethnicity, healthcare coverage. This study was probably now at least 12 years ago, maybe 15 years ago. And they did show exactly what you were saying, that even if you corrected for all of those factors that we think might affect access to healthcare, there still was a difference in outcome. And sorry, Siri is climbing up on my shoulder here.
That's funny.
So you know, that's part of, I don't know how much of that is trust, how much of that is concern by the physician, how much time do they spend with the patient, educating the patient. You know, there's just, it is so complex and there's so many things to be addressed, and trust is a big part of that, I think. And of course, in New Mexico, then we have the huge Native American population that has very, very similar history of severe abuse, and so understandably very a severe lack of trust that can be a big part of everything. And then all of the economic issues. Again, we're back to economics. But
Yes, yes, we are.
Secretary, I actually had a question. We have several, Wayne mentioned the 1815 grant that is a lot of this work is funded under, and we have a few of our contractors who work on the electronic health records part of the 1815 grant. Can you talk a little bit about, you know, as a provider and as somebody who has actively worked in leadership with health systems, can you talk a little bit about building that relationship with the health systems to encourage them to partner with the DOH and our contractors on the electronic health records piece?
Yeah, it's a great question, and thank you. I think one of the things is actually having the health system recognize the value to them of the partnership and getting in to have those conversations. So when I was at COPH, the College of Population Health, we were beginning to have conversations with their value-based care initiative, with the folks leading that. And so there's a population health coordinator in the hospital, but then we had a College of Population Health. So we were considered more the academic researchy people, and these are the clinically oriented, let's just look at the data that we have. But we wanted to partner with them, and we did, to help them realize how much more we could get in depth with looking at the data and giving them information that would then improve outcomes for their patients. So I think it's not a sales pitch, but I think you have to get before the people in the healthcare system and have the conversation and discuss what you can offer. So as far as like DOH, what we can offer is understanding from an epidemiologic public health perspective what you need to do with a given patient so that you have a better outcome, you actually save money, and the patient really is happier and has a better quality of life, and what that looks like. And so it's really those conversations and coming up with the policies that will influence how you use the electronic health record.
Give it 15 more seconds to see if we have any other questions or comments. Okay, thank you so much, Dr. Collins. It was an honor to have you here. We truly appreciate you taking time out of your day to support these efforts.
Well, thank you for having me, and I really appreciate the opportunity, and you have a good day.
Thanks, you too.
Okay, bye-bye.
Bye. We will now break until 1:15 when Dr. Jennifer Gomez Chavez of the University of New Mexico's Health Sciences Center's Office of Diversity, Equity, and Inclusion will lead a session on collective impact. This Zoom will stay live during the break, so you all are free to leave your cameras on. You're free to chat with each other. You can chat via camera and microphone or over the chat box. Otherwise, we will see you at 1:15.